Right next to me is Julie Gerberding, who is the Executive Vice President and Chief Patient Officer at Merck. Many of you in the room, I'm sure, know that Julie was a former director of the Center for Disease Control. She's covered many crises, from anthrax to, what haven't you covered? I should probably ask you.
Zika.
Yeah, Zika, we will find out too. But a lot of experience through public health crisis. Next to Julie, we have Bob Bazell. He is an adjunct professor of molecular, cellular, and developmental biology at Yale University, where he's currently teaching a class on public health communications. He was, a lot of you may know Bob because he was at NBC News for over 3 decades, almost 4, I should say, as the former chief science and health correspondent. And next to Bob is Wada El-Sadr. She is the Mathilde Krim Afar Chair of Global Health at Columbia University. She also founded and currently directs ICAP, which works in sub-Saharan Africa, Central Asia, and the US in partnership with governmental and non-governmental organizations building in-country capacity for HIV. So thank you very much. Welcome to all of you. I just wanted to pick up the conversation from where Laura left off. And she mentioned the Rockefeller report that News Deeply wrote last year. And I thought what was notable about that report was they gave examples of recent crisis that we have experienced. One of them was, of course, the SARS crisis in Asia, and the other one was the Ebola crisis. With those two outbreaks, we had a very different reaction to how governments and the world, for that matter, dealt with that. In SARS, the Singapore government was able to get rid of the disease within 3 months because of the way that it really took over the communication of what was going on, as well as at the same time telling people how to prevent getting the disease. Whereas Ebola, we all knew, if anyone was watching cable news, the hysteria that roared through the media. I remember once turning on the TV, and actually a journalist was doing a live shot from a bar that they thought one of the aid workers may have gone to. And so, that fueled a lot of hysteria. So we're gonna pick up this conversation, but I think appropriately, let's start with Zika. And let's start, Julie, with you. Tell us how you feel the communication of this disease is going, and whether or not the media has fairly addressed how much we need to worry.
Well, first of all, thank you. And thanks for doing this and kind of bringing us all together to focus on the issues. Zika is hard. I think the perspective depends on where you are in the world. So we're actually in one of the most difficult environments in the US because except for a few communities in Florida, it's not here. And we have a pretty good handle on when and how it might move because of its mosquito vector nature and the fact that we do have surveillance in the United States. So actually, that's the tricky thing. When it's here, it's newsworthy. When it's there, it's not as newsworthy. And I think we're kind of struggling to figure out how to balance the scope and scale of the impact that this really is having in many parts of the world with what does it mean to the average United States media consumer, which unless you're directly in the line of fire is probably not so dominant. Having said that, many of us work for global companies. I have employees in the region. It's an issue that we work on every week, but I would say it's pretty much under the radar screen.
Bob, what's your opinion, being a journalist yourself? Obviously we heard a lot about Zika during the Olympics. It seemed like it was a focus of a lot of mainstream media. Seems to have died down.
Yeah, I have not covered Zika because I left NBC before the severity of the birth defects was noticed. I think I agree. It's complicated. It depends on a corporation. It depends on a city. We were in preparing for this talk. We mentioned that there are more Zika cases in New York City than any place else in the United States, and the reason for that is that so many people travel from here, and so many people have relatives there. And one of the key principles that I've learned in learning how to teach public health is the concept of a segmented audience, and that very different people need very different messages. If you're young and could be pregnant, or if you're the partner of somebody who could be pregnant, it's a very different message from somebody who has no chance to do that. If you have relatives or you wish to travel to a place that has possible ongoing transmission, that's a different message. If you have a corporation that has people in those areas. So there are a lot of messages for a lot of people, and in an environment where the information is changing almost by the minute. And that's really one of the toughest ones I've seen, because I go back to my two co-panelists here to the days of HIV, and HIV, as awful as it is in the world, probably the world's greatest plague ever, but it seemed to unfold much more slowly. And because we learn more slowly. Now obviously some of the reasons that Zika is unfolding more quickly has to do with molecular technology and that sort of thing. But still, this is something that's happening so quickly that it's very, very difficult. And I would not have a single piece of advice for anybody other than my sympathies who has to deal with this.
Wafa, what do you make of Zika, and how it's being portrayed, and what needs to happen?
Yeah, I think in a lot of ways it is complex, because I think it largely, I mean, the concern is largely amongst the one particular group of our population, which are pregnant women or women who would like to become pregnant, and that's where most of the fear is based. So that also complicates the messaging as well. Because for others it's a relatively mild and uneventful disease for most. I think what's been a struggle has been for public health, I believe, is this, how do we mobilize resources? How do we respond to something that is complicated, that's not happening very visibly in our midst, but yet is affecting, hundreds of thousands of people, either in countries that are very near or where people visit, and how does public health, how do we message this so that we're able to mobilize the public health response that is necessary to be able to prevent an outbreak of Zika in this country as well as to control Zika elsewhere. And I think that's been very complicated because it seems far away. It seems to, a few people are worried about it. It doesn't seem to, it's been hard to generate, I think, the response that one wants to see for something like Zika because of that, because of the perception that it's not here in our midst today. It's somewhere else. It's affecting other people and maybe a small segment of us. So I think those are the difficult issues that public health needs, really needs the communication experts to be able to highlight, why this is important in the context that it's not right here in our midst.
But in the case of Ebola, hysteria, once it was in the U.S. Or patients who were traveling, who came back to the U.S., hysteria broke out. I mean, you remember that, Julie. So, it's a fine line, right, between really telling people, all of a sudden, if Zika comes to the U.S., will we do the same thing? Will the hysteria prevail?
But Ebola had all of the elements of a great television drama, Armageddon type stories, and I think it was just too tempting for people not to feed into that. When I turned on the television and saw them removing the toilet from the person in quarantine's apartment, that was it. I mean, I just said, we have failed. Somehow, from a communication standpoint, we have really failed to effectively communicate how this disease is and isn't spread. But Ebola to me is more like SARS because of the person-to-person nature of the transmission, the health worker risk. There were a lot of commonalities in the modes of transmission and what it would mean in a developed country with a health system and who really was at risk. And I don't think we really help people connect those dots. that, this is it's a risk, but it's a manageable risk. We can, take rational steps to protect and help people, and it just took on a life of its own. And then that was complicated by what I think were poorly informed, at best, decisions made by some government leaders or some local government leaders around what to do at a given community level. I had the chance to meet with the former state health officer in Texas several weeks after the situation there unfolded, and the backstory was just remarkable of what was actually happening and what they were contending with in terms of what state would take trash into the landfill. And it was just spinning out into very irrational decision making that, of course, helped expand the fear of the public, not quench the fear.
Can you tell us a little bit? You compare it to SARS. Obviously, SARS did not impact the U.S. the way that it impacted Asian countries. But when you were at the CDC, what were you thinking about in terms of how you were going to communicate? Because you have plane loads of people coming from Asia to the U.S. Obviously, you had to keep an eye on the situation. So when you were at the CDC, what types of planning were you taking part in order to, in the event that there would be a huge maybe SARS outbreak in the U.S.?
One of the things that we were very mindful of was what was happening in Toronto, because Toronto is not Singapore. Toronto is
right across the border.
It's right across the border. But I think it goes back to what Bob was saying earlier. It's segmentation. I like to think of communication by objective. So what is it that we want, what outcome are we trying to achieve with the communication that we're creating, and then what is the best way to deliver what message in what channel to what set of people. If you don't know what you're trying to accomplish, you can be all over the map. So if the goal is to help hospitals or health personnel recognize that they need to take a travel history when someone comes to the emergency room, that's one very targeted kind of communication. If it's to let Americans know it's okay to travel globally, but there's a travel advisory in these 3 countries, that's a different kind of communication. And I think segmenting that and mapping it out by where you are in what you know is really the only way to really help people do what they need to do and know what they need to know.
There's a set of hypotheses about how to conduct public health communications that I think that Julie has heard, and I had a chance to review several videotapes of her response to SARS. There's a couple things about SARS in the United States. In the United States, it didn't cause the kind of panic that even Ebola did, even though it had more of a candidate to do it, because it was right during the run-up to the invasion of Iraq. So it wasn't getting the kind of news coverage. It would have gotten the kind of news coverage that Ebola got times 10 if that hadn't been the case. But one thing that, one of these principles that I think is very important is that fear can be your friend if you're a public health communicator. People worry a lot about fear, but actually fear makes people pay attention. They also worry about panic, but panic almost never happens. But if people are fearful, you've got their attention. And one of the things that in reviewing the tapes is that you never said there is not going to be an outbreak in the United States. You would always start by saying it is a possibility that there could be an outbreak in the United States, and we have to prepare for this, but we have no evidence of it at this time, which is a message that keeps up the level of concern, but doesn't panic people. And I thought that was very well handled, but I suspect that you had a bit of guidance in how to
I had Barbara.
Yeah, right.
I had Barbara Reynolds, who is the risk communication leader at CDC, who is very, very instrumental in helping think through. And I agree with you completely. People, it's normal to be afraid. Mm-hmm. It's normal to be afraid of Ebola. It's normal to be afraid of SARS. And the worst thing you can do is try to over-reassure people or to, you know, keep them, we don't need to worry about this, it's okay, we've got it covered. No, because then when something happens, or when a patient comes to the United States, then they don't trust you, you know, but you told us, and now this has happened. So I think it is a lot better to be honest about what might happen or what could happen, but also reassure people it hasn't happened yet. When it does, we're taking steps, and we'll manage it.
But Bob, it's a fine line though, right? Because I mean, you saw what happened here with Ebola. So
yes, but Ebola didn't. It happened, and it was really crazy, but just for a few weeks. And after a while, people get a pretty good sense of what's going on. It was a very difficult message to communicate, and I feel very sorry for Dr. Frieden to have to have done it, because the transmissibility of the Ebola virus is not like the common cold, but it's also not like HIV, and it's in between there, and explaining that, and even when it wasn't completely understood, because there had not been a gigantic outbreak of Ebola anyplace in the world before, and there were not that many people who had experienced it. So that was a tough part, and there was a few, and so when the few cases, when the 2 nurses in Texas were infected, it was suddenly, oh, you've betrayed us. You said if we take precautions, it won't happen, but then it happened. And there was a momentary loss of confidence. But people catch on pretty quickly that Ebola wasn't going to spread and come take their children away.
Yeah,
Go
I mean,
ahead.
In the
I
United
think
States.
in the United States, yeah, I think also what's interesting is, yes, I think fear is important and often valuable, but it's fearing the right thing versus fearing the wrong thing. And that's the role of public health and communication working together, is to have people focus on what they should rightfully be afraid of rather than the wrong things. And I think that's where the message has to be fine-tuned. I think people were afraid in HIV, in the years of HIV, of catching HIV from sitting next to somebody at a dinner table. So I think, again, the importance of trying to transmit sometimes complex information about transmission, how things are transmitted, not transmitted, what's really risk, what's the level of risk. These are very, very complex issues to try to transmit to the population at large, but I think they can be transmitted effectively, but so long as we can really guide people to, you know, to really focus on what's important, and to try to dismiss or move away from things that are irrational fears or things that they should really not worry about. So I think there's a fine balance
Are
there.
we getting better though? Like when you, all of you, I'm sure, can comment on this, but like when HIV was first coming into the news, like you said, there was a lot of fear, not understanding exactly what this is. When you think back to how that was communicated, and now, you know, we've seen several different types of diseases or come and in phases, are we getting better at that communication?
I think we are. I mean, I think in many ways, yes. I think there's much more transparency and openness, and I think people have learned the lesson of you better share the information. It's much better to share it rather than have to apologize that you knew something and didn't share it. So I think there's more transparency. I think there's more consistency in terms of the messaging going out, that there's rapidly being out there and talking about the issues. I think that's been extremely helpful, and that's much better than in the AIDS years where we didn't know what caused HIV. That's another issue, but also there was a lot of reluctance to admit that it was here in this country and how it's transmitted and so on. So I think that transparency, the willingness to be out there and talking consistently about what's going on by officials, I think has been very valuable. I think there are also so many more media points than there ever was a few years ago. I mean, in the days of AIDS, we listened to you and a few others. Now it's everywhere.
But that can be a problem too,
So
right?
that is a problem,
Yeah.
but people have a lot of sources of information. I think they can triangulate the information, and that's where I believe also very much in the need for a trusted spokesperson. I always remember C. Everett Koop, our favorite Surgeon General, who was kind of a voice of reason in the chaos of HIV epidemic. And having now leadership at the city level or at the CDC or NIH, people who are consistent, very good at communication, but also consistent, they become trusted, and that's very helpful, the continuity of a voice that's addressing an issue.
So you would say it's more important to have one main voice who's controlling the information that rather than lots of different voices?
I think it's inevitable there'll be a lot of different voices. I think there needs to be a trusted source of information. And often that's somebody high up who knows about what's happening very intimately. I think that's very valuable, and that person be trusted and can transmit the information very effectively and very clearly and consistently.
Yeah,
I think that helps.
I want to follow up on that point, because I think that there's a lot of craziness on the internet, and we talk about that a lot, and on cable television and talk radio, conspiracy theories, and a lot of it will devolve into discussions about health. But I don't think that when people are truly concerned, they turn to that. You'll hear people saying that, this has been my experience, but the person who is in charge, whether it was Julie at the CDC or whether it's somebody else, Tony Fauci is, who will come forward and in a reasoned way become the voice that people listen to, because these people are afraid, and they have a sense of who has real information and who hasn't. And it's important that people like Julie and Tony have a track record of not giving untruths and being the reliable source of information. And during a time of crisis, people do turn to that. And I worry less about internet crazy stuff than I think that we spend too much time worrying about that.
I agree with you, although I think there's a generational element, and the data that the Harvard group had put together on the anthrax crisis really suggested that if you look at government officials, including the CDC director or the NIH director or the secretary or the head of the FBI, people would be okay receiving information from those resources, but the preferred source of information about anthrax, at least, was their doctor. And so, I think we miss opportunities sometimes at the local level to really engage the local medical community as part of the communication challenge or channel, because that is the most trusted person. And, we have a challenge to try to get information and to figure out at the local level who's the most respected person. That may be the local public health official. And I think that's why we put so much effort into things like the Health Alert Network and other CDC tools that try to put information into the hands of the most local medical authority, because we trusted their ability to translate that with credibility in the local radio, the local television channels, et cetera.
And an example of that is, of course, the Ebola and the BBC really partnering up with the local stations in African countries and delivering the message. It was a trusted source among people, and it wasn't, some foreigner coming in and saying this is what's happening. It was really a trusted source, and I think that really highlighted the importance of having the on-the-ground local messaging. But
let me just quickly say that on the anthrax thing, which reminded me, you as the government, not you personally, but you ended up behind the 8 ball, because Secretary Thompson said that the first person to contract anthrax had gotten it from drinking the water. And it didn't take any reporter about more than 2 seconds to see that you couldn't catch anthrax that way. So you had the highest health official in the country saying an untruth, and it's very hard to catch up with. When something like that happens, it's very, and that's why people in government who deal with health issues need to have a communications team on board from the very start and just not mouth off right away.
There's also a lesson I think I've learned coming into a new administration that we should keep in mind, and that is new leaders, particularly new health leaders, tend to over-reassure when they're early in their tenure, because they're anxious about demonstrating that they're as good as the people who just left. And so they may promise vaccine by such and such a date, or they will reassure about the source of an outbreak, et cetera, et cetera. So, we're coming into a vulnerable period again where we need the stability of the residual people who aren't changing over to really be front and center. And for the media, I hope, that is a kind of a clue as to where to go for trusted information, that the new people might not always have the full experience and balance to have the judgment and the perspective that some of us who've learned our lessons the hard way, keep in the back of our mind.
I do imagine, though, that anthrax was a double challenge in that it was you didn't know where the source was, right, for a very long time. So that, I'm wondering how you dealt with that, because, with other diseases, you can say, you can do this to prevent getting this, right? But with anthrax, it was terrorism, in a way, and I remember the stories, and I'm sure everyone looked at their piece of mail after that, and thought, oh, should I open this if I don't know who it's from? So what type of messaging went in, and what were you considering when you didn't really know where the source was? How can you give reassurance?
Well, I don't think we could give much reassurance. I mean, the World Trade Centers and the Pentagon had been attacked and a plane had come down, and then 28 days later we have anthrax in the mail. So, I don't think we could give a lot of assurance about what we knew or what we could predict would happen. We could describe what had happened, and we could describe what we are doing about it. But I think that was the wake-up call, that business as usual, scientific communication was not going to be good enough when we're dealing with the uncertainties of public health emergencies or, God forbid, terrorism. So it was really, for me, a frame shift in how we began to understand what is the role of public health in that kind of crisis. So no answer, but just a lot of learning and some experimentation that was going on. Well, let's try this and see how this one works. What we did learn very early was not talking was bad, and not deciding something quickly was bad. And so that even if we didn't know, we were better off saying, here's what we've seen, we don't know, but here's what we're doing, was much better than radio silence. Mm-hmm. So you were one of the people poking us in that period of time, but I think we really learned.
I also had the experience of working at NBC, which was the second place that was a target, and
That's right.
then seeing how people responded, as well as having to report on it, which was a critical set of lessons in there. But one of the things that was fascinating was inside NBC, the people that were closest to the letter that went to Tom Brokaw's secretary were far less fearful than people on other floors. And this happens a lot of times. And I saw this recently at Bellevue Hospital when they were treating the young doctor who had come back from volunteering overseas, that people who were actually in the wards where he was being treated were not worried at all. They had been well educated, but people were refusing to go to clinics across the street because.
But that's the same with HIV. I mean, the people who are dealing with patients with HIV did not fear HIV, but the people who are not. So I think more, you're more confident, you're more familiar, you're more knowledgeable. So I think that's another part of it, maybe that explains that as well.
Right,
Yeah.
exactly.
I just want to, we're running out of time, so I want to see if there's any questions before we move this program on. Does anyone in the audience have any questions for our panelists? Please.
So my question is, how do you tackle the issue of getting information to people who really need it, but aren't seeking it and aren't particularly interested?
Do you want to give an example of what you mean?
Well, I mean, AIDS, HIV would be probably an excellent example. You wanted to look at that while I do.
Yeah, no, I think it's a good question because, I mean, we're tackling this in this country of people who are at risk for HIV, who really should know about HIV but are not interested. I think part of it is trying to think of methods to utilize that reach the population. And I think Julie mentioned this is for young people trying to use new media methodologies, for example, and bring the information to them indirectly, not directly focus on HIV as an example, but to use other issues and interests that they may have. So I think that's been effective in reaching young people. I think focusing on health issues, on some of the not on fear, but on general health issues, for example, or things they're interested in, tying these messages to having spokespeople or people that they respect and can relate to, young people that they can respect and relate to. So I think it's really identifying people that can reach the population for you, as well as using methods of communication that they're much more attuned to.
Well, and excuse me, for those of you who aren't involved in public health communications, it can really be broken into two categories. And one is crisis communications that we've been talking about, Zika and Ebola, and the other is trying to get people who are at risk for HIV to either get tested, or if even often they've been tested and they know they're positive and they won't take their meds, even though we know it prevents transmission and makes them healthier. So, but that's almost like trying to get people to eat a good diet as well. That's a long-term problem that requires moving a big boulder slowly, whereas the other things are, you wake up in the morning and you've got a whole lot of worry.
I mean, I think some of the same principles apply. You need a trusted person. You need to be open and direct and use the method that can reach the audience.
And part of it, I mean, this is, I think, what mainstream media struggles with. It's keeping the story in the headlines, right? I mean, if there's not a reason for it to be in the headlines, it's not going to get coverage, right?
Well, I think that's a challenge with Zika now. In the winter coming is in our winter there'll be less mosquitoes. It's going to be off the radar, but it's going to be on the radar somewhere else in the world, and that's the struggle we all face.
We have another question there, and then.
Thank you. Yvonne McPherson from BBC Media Action. I wanted to challenge the view that fear can sometimes be a useful tool. And experience has shown that when there are fear-based tactics, it has unintended consequences, which are namely stigmatizing people who actually do contract the concerned condition and driving people underground and not wanting to get tested. And so I personally would caution any strategy that includes fear. I understand that this is to a lesser extent when we're talking about Zika, but as far as we're concerned at BBC Media Action, we wouldn't ever choose fear as a communication strategy.
Well,
Please comment.
I would never advocate, nor did I, saying we should create fear. I think that we should use fear when it's
acknowledge it.
Yeah, right. Because when people are fearful, they pay attention. I don't think you should try to scare people with untruths or any other method to try to as a communication strategy, but just use it as an opportunity was what I was saying.
I think I agree with you. I think fear is not an effective intervention that you want to utilize. I think it's more of trying to utilize an opportunistically maybe caution or fear that some people may have.
The one thing I know we're running out of time. I just want to interject this because I think it's such an important point, which is that technology has aided anyone to pass a message out very quickly, right? And so this world we live in where people can send a tweet very quickly and there's a lot of conversation going even maybe before a public official has the time to stand up and say this is what's going on. Does that concern any of you? Is that a good thing or is that a bad thing? Because in some ways, you know, if the conversation's getting out quickly, sometimes that could be a good thing, but you lose control over it. So I just wanted to hear your opinions on the technology aspect of it. Julie, do you want to start? Because
well, whether it's good or bad doesn't matter because it is.
Mm-hmm. Yeah.
So the question then is, how do we manage that? And you know, obviously CDC is tweeting. You know, so they're just learning how to get out there as fast, and you know, they have a lot of followers, and you know, so that you have to build your own systems, and that's, you know, it's true with vaccine hesitancy. It's true with all kinds of issues where there is a lot of communication going on over here, and you have to counterweight it with communication over here. But the more you utilize those channels and strengthen those cascades and networks, the more people you can reach quickly. And again, that's why the kind of public health tools that are intentionally created to push things fast into the local opinion leaders become so critical.
right.
I think also traditionally in public health, I think people used to be much more hesitant to share half-baked information or to have, not to want to be certain, to want to know for sure, to be able to share data. I think now there's much more of a willingness, realizing that things are out there, much more willingness to share uncertainty, but to be out there earlier.
The word that saved more lives, I think, than any other word in the CDC vocabulary is interim. Because by putting something as interim guidance for X, it allows them to get something out fast, knowing that maybe more science will come and it will have to
It's going to change,
it'll
revise.
have to change.